tell you a story this morning about a clinical trial that we've conducted with exercise training in children treated for brain tumors. And I'm hoping that by the end I convince you that I think we're at the cusp of a paradigm shift in how we address neuropsychological late effects in our children. That I think we are moving to a place where we're going to treat late effects in the same way that we treat primary disease, with treatments that are carried forward in an ongoing basis for our patients. So this audience knows this very well, that there's a cost to the cure for brain tumors. Even in children treated with surgery only, you see trauma in tissue from the impact of the tumor itself, as well as the resection. And then in children with more aggressive disease that require radiation therapy, there's a cascade of effects in the brain that have an impact on the neural stem cell niche, for example, that leads to disruption in the blood-brain barrier and structural damage in white matter. So we can see this here in a TBFS analysis where we see all these areas of red that we show are areas of compromised white matter in children treated with craniospinal radiation, as well as damage to specific nuclei in the brain, such as the hippocampus. And we've recently shown here that the volume, the size of the hippocampus in children treated with craniospinal radiation, when it's normalized to total brain volume, is smaller. And this has an impact on the brain function and the cognitive functioning, and we're going to hear much more about that later on in the morning from the rest of the speakers. So the question then is, what can we do to stimulate processes in the brain that have an impact on mitigating these late effects? There's a long literature in the animal work looking at wheel running and its impact on the neural stem cell niche and fostering neurogenesis and gliogenesis. So my colleague at the Hospital for Sick Children, as an example, Paul Franklin has mice run versus mice who don't run. And they label the precursor cells and then look at their progeny and determine that there's greater neurons, new neurons in the dentate and CA3 region of the hippocampus. Indeed, it was the original work done by the Swedish group that inspired us to do our exercise trial, that work where they demonstrated in rat pups who were radiated that running has an impact on fostering neurogenesis. You can also see the same thing for gliogenesis as well. So basically we developed gym class for children with brain tumors. They would come for a 12-week period of time, 3 times a week for about an hour and a half, and engage in a number of activities intended to raise their heart rate and improve their cardiorespiratory fitness. They all wear a heart rate monitor so we can determine they are increasing their heart rate to 80% of their peak heart rate that we tested at baseline. And then there's a period of activities they do, and the children love this opportunity, you can see from the pictures. So here's our consort diagram. When we went through all the patients we had, about 80 were eligible and met our eligibility criteria for things like 2 years post-diagnosis, between 6 and 17 years of age, treated for a tumor with either focal or craniospinal radiation. And we allocated them to either start training immediately and then have a 10-week period of no training, or the opposite. So there's crossover in between. Here are the patient characteristics, and what I want to highlight is this group of patients was a mean time since diagnosis of about 6 years. So these are patients who are well past the period of trauma from the injury. We looked at fitness, motor proficiency, and what I'll talk about today is neuroimaging and cognitive outcomes in these patients. So we saw them at baseline, and then they either did the exercise training or no training, and then we tested them, and then there was crossover, and then we tested them again, and we calculated different scores. So period 2 testing minus baseline and period 1 testing minus baseline to look at change over time in this population of kids. We acquired a T1 anatomic scan to look at the volume of the hippocampus. We acquired DTI data, and I can tell you about those parameters if you're interested. As well as we conducted computerized testing of the patients with things like a matching to sample task that looks at attention span, a delayed matching to sample task that looks at short-term memory, a rapid visual processing task that is a task of sustained attention, and some processing speed tasks. And we calculated accuracy and latency data across all those tasks and looked at change over time. So here's the data. So we used linear mixed modeling, and we modeled the effects of time, training, and carryover effects. Time to control for potential maturation effects that are associated with training, as well as potential practice effects on our cognitive tasks. And well, let's look at the DTI first. So this is a longitudinal comparison between pre and post exercise, and all the areas of red are areas of increased FA, so increased structure of white matter following exercise, notably in interhemispheric and callosal regions. And when we look at that statistically, there's a significant training effect. So here we have mean change in FA. So we see a training effect and a carryover effect, and I think this is best seen in the raw data. So here are our group who did no training first and then training, and the group that trained and then did no training. And so you can see very robustly the increase in white matter structure following training, as well as for the 9 kids who had the carryover. So this is a period of no training. There's ongoing improvement in FA. This could be due to ongoing processes that we elicited, or they may have just continued exercising and not telling us about it. The same pattern we see for the hippocampus. So we segmented the hippocampus. This is radiological space, so right and left. And we see a training effect again, a very robust training effect with increased hippocampal size following exercise training in this group, as well as a carryover effect. And you can see it here again very dramatically in the raw test difference scores. The children who had no training versus training, and then the children, these are the same children again, in the carryover effect. Quite compelling as far as I'm concerned that we're seeing these real, in the order of a 3 or 4% increase in the size of the hippocampus. And we saw it in our cognitive data. When we looked, we didn't see it in any changes in accuracy, but when we look at reaction time, these children got faster, which is quite compelling for me because the typical phenotype of these children is they slow down, they get slower over time. Following training, we saw a decrease in the reaction time as well as an ongoing carryover effect. And here you can see, so now performance below the line is indicative of better performance. So we saw increases in the structure of white matter, particularly in interhemispheric regions. We saw increased hippocampal volume. We saw decreased reaction time, indicative of improved cognitive performance. And we saw this carryover effect across all tasks, suggesting that either we're engaging some process, some endogenous process in the brain that carries on, or as I said, maybe the kids are continuing to exercise. And I just want to highlight, this is in kids 6 years following diagnosis and treatment, suggesting that we have an alternative for addressing some of these late effects, even in longer-term survivors. So I hope I've convinced you that physical exercise, I think, shows significant promise in helping the brain recover from primary therapy. And I think this is a part of an ongoing paradigm shift when we consider neuropsychological late effects. You know, we started by documenting just those effects, both in our studies as well as with parents. These are the problems you're going to experience. We've moved to trying to manage and compensate for those difficulties. I think we're now entering an era of active treatment and brain repair, where we consider late effects in the same way we consider primary disease. We can apply multiple modalities to actually help the brain repair and heal. I think the foundation for these types of studies were the pharmacological and cognitive rehabilitation studies that Ray Multern started and then carried on by Heather Conklin, as well as Rob Butler, carried forward into the computerized training types of studies that Christy Hardy is running with COG right now, and I know Heather also has a cognitive component to the SGMD13. And then the brain protection and repair studies, so the exercise studies like I've shown you, as well as the use of active agents to protect the brain. And I'll direct your attention again to the Swedish group who had a poster here looking at lithium in animal models as a method for protecting the brain. And what I see us doing is combining these modalities and making a real difference in terms of helping the brain recover from the late effects and improve children's quality of life. I need to thank the members of my lab, particularly Liddy Riggs, who was really helpful in organizing the data. I need to acknowledge my collaborators, certainly Eric, who is a great leader for our brain tumor program, all the therapists who actually did these training with the children, as well as my funders. Thank you very much.